Hi, everybody. I'm truly honored to moderate this panel of experts, and all of the wonderful experts who've generously agreed to be on this panel have already been introduced at their respective talks, and they are Dr. Rick Moss, Dr. Dennis Hadji-Liadas, Dr. Jim Schmiel, Dr. Carolyn O'Corey, Dr. Virginia O'Hare, and Dr. Lisa Scher, and Dr. Sriram Vaidyanathan, Dr. Nicole Irizarry, and Dr. Doug Conrad, and finally, Dr. Marie Egan. This is the largest panel we've ever had, thanks to this being virtual. So this will be a wonderful challenge. We love a challenge. This is your panel, and all questions are welcome. Make sure that you put your questions in the Q&A box. Having said this, when you ask a question, also please specify the panelist that you're directing your question to, and avoid making your questions too specific to you or your child's case, and do not name your care team. This is not a time for statements, and it's a time to glean insights from this outstanding and diverse panel of experts. So with that, I would like to start off with one question before we go to the Q&A box, and just kind of ask everybody about what's one thing you'd like the audience to take away from this conference. You've all given such insightful sessions in your respective fields, and there are many who weren't able to catch every session. So could each of you share just one nugget of information or tip within your expertise that you'd like the CF community to know? And this will give folks an idea of what they missed and go back and listen to when the recordings are available. And with that, so I'll just kind of pick some people. And so if Dr. Moss, if you could maybe give us something, give everyone something to take away with.
Well, sticking to my topic of COVID, in the context of this conference and going forward, I think it's very important for everyone to make sure that you are communicating with your care center about visits, about procedures, and about research, because all of these things are in tremendous flux right now. And so it's going to be very important to make sure that you have good information. Pay attention to your providers and try and keep the noise outside to a minimum, because we're going to be navigating this for many months to come, probably several years to come. Even if a vaccine is available, the rollout of that may take a year or two, given the scope of the problem. So there's going to be a very long period of negotiating a lot of unknowns, and therefore, I would say communication is going to be at the top of anyone's priority list.
Thank you. Dr. Vidyanathan?
So I'll stick to my topic of gene-edited stem cell therapies. I would say that it's a work in progress, and hopefully, there's good news like in the next 5 to 10 years or something like that, so keep your eyes open. But in the meantime, there are several other studies and trials going on for different approaches for durable therapies, including mRNA therapies and other gene therapies, so stay informed.
Excellent. And Dr. Schmiel?
Yeah, so I think the talks and the sessions at this meeting, I hope what everybody got a chance to see is the vast array of research being done on all aspects of the cystic fibrosis. And it's not just limited to one area and like, oh, we've got highly effective modulators now. We can take our foot off the gas. And that research is going to continue in all areas because for several years, there wasn't many things we could offer to our patients. And now, with all the new technology and therapies available, we're going to see even more diverse research than we have in the past.
Oh, terrific. Thank you. And Dr. Scher?
Because we'll appreciate mental health is so important, and especially in the times of COVID, more than ever, right? For all of us well-being, and of course, people and family of people with CF. And my talk was focusing on psychiatry in CF. So if you're not working with a psychiatrist and you think that's something that you might benefit with, first of all, talk to your team. Most likely your CF team, your social workers have connections with psychiatrists. And, it's important to be mindful of drug-drug interactions when taking psychotropic medications.
Excellent. And Dr. O'Hare?
Hi, thanks. I guess my takeaway would be if you're anxious, particularly during this pandemic, and if you're dealing with shortness of breath related anxiety or just anxiety in general, then we're very hopeful that acceptance and commitment therapy, or ACT, could be a useful treatment for you. And we have this 6-week study where patients are randomized to either ACT or supportive psychotherapy. And I'll put my email in the chat if you are interested, or if you have a family member who's interested, shoot me an email. And if you don't want to do the study, but you're just kind of interested in ACT in general, I'm also going to put a really great self-help option in the chat too.
Terrific. And Dr. Okori?
So my topic was on sleep. So I think I would just encourage everyone to bring up sleep issues, concerns, and to their CF providers. We know that sleep is overarching in all aspects of your health and your life, from mental health to even your lung function. So I would just encourage everyone to bring it up during their visits.
Thank you. And Dr. Hadjiliadis?
My topic was mostly on cancer in CF, but my take-home point is going to be a little more general. Be an advocate for yourself. Make sure that you are informed, and ask your team about new information, new studies, new things. In general, start preparing that your life might be a lot longer than you originally expected, and therefore make sure that you do things to prevent complications from going forward.
Excellent. Dr. Irizarry?
Thank you for the opportunity. Is it okay if I share my screen? Because I actually made a slide in prep for this. All right, so I had a couple of questions yesterday in regards to what are some things that I recommended and what people could take home with them. And so I'm going to share my screen and say that if you are curious about heart rate max and where you should exercise, here is the calculation that I think you should use. 70% of your heart rate max is the current recommendation. There's nothing wrong with doing it at 60 and 80%, and some people even go up to 90. I still think checking in with your team to find out if this is okay, because everybody's different and everybody may have a little bit of an underlying caveat that we need to play in the mix. And then here were 2 things on YouTube with some pictures included that I think people can look at to give them some guidelines and participation for exercising in that high intensity interval training capacity. So I just wanted to share that with you guys. And if you want to take a screenshot, you are more than welcome to do that. And I'm going to stop sharing my screen.
I love it. You read my mind what the question would be, I guess. And then Dr. Conrad?
Yes, hi. A couple things. One, with respect to the talk I gave on phage therapy, it's, I think it has the promise, we don't really know yet, but it has the promise of being a very useful adjunct and possibly even a personalized way of providing anti-infective care. And there are going to be trials opening up over the next year, and I'm strongly encouraging everybody who's potentially eligible to participate in those if they can, because just like any other therapy, we have to get through all this. There are certain steps and stages we have to go through. I also like, just as a clinician working with adult patients, I want to echo what Rick and a number of others have said, the importance of really communicating well with your providers. This is, I'm sensing an incredible amount of stress and isolation in our patient population, and you've got these teams put together for the patients, and strongly encourage you to use them. And also, don't forget your airway clearance, okay? Even if you're on modulator therapy, don't forget your airway clearance.
Okay, and for the grand finale, Dr. Egan?
My talk was on emerging technologies and potential therapies in the future. And so I hope everyone sees how robust the pipeline is and how exciting things are. I think that and so not to lose hope and to understand that there's a lot of work to be done and many people working on it. I think that in the short run, though, I would just have to echo what all the other panelists have already said as far as in the here and now. All these technologies and these potential therapies will be coming down the pipeline, but the most important thing for folks to do is to try to keep themselves as healthy as possible now. And that health would include their mental health, their physical health, and making sure they stay in touch with their care teams and their care plans. So.
Okay, thank you very much. I will go to the Q&A now. And the first question is, what research and treatments are currently being studied for CF chronic pain and joint inflammation? It says any doctors, but maybe Dr. Schmiel can start that off.
Yeah, I mean, that's a great question. I think we have seen, I will say that there, to my knowledge, and I am not a expert, the other panelists may know on the clinical trials going on with arthritis and CF. I do not know of a clinical trial of arthritis and CF. There are some very early preclinical studies. I will tell you that in some of the anti-inflammatory trials, and certainly in personal experience when I was in Cleveland, that the patients who got the high dose ibuprofen had, it was interesting. It always seemed to be the older teenage women or the young 20 women who had the most problem with this arthritis. And when they started a high dose ibuprofen, we saw much less of an incidence. But this is an area that has been, in general, understudied in CF. We're so focused on the lung disease and the GI tract, that we're just now starting to branch out. It wasn't that long ago when we did nothing about mental health and we weren't doing any studies. And as patients are living longer and we're improving therapies, these other issues are starting to come into the fore of this. In fact, I just finished studying a book on CF with Stephanie Davis and Margaret Rosenfeld, and we had a very difficult time finding someone to write the rheumatology chapter. We talked to the CF Foundation leadership. They gave us some names, and the individual said, well, I'm not really doing that anymore. And we finally found a person in France to actually write the chapter. So this is an understudied area. Hopefully some of the anti-inflammatory trials will pan out that will help that. But, I believe as therapies improve, we'll start to see other things being addressed that haven't typically been addressed. I don't know if any of the other panelists want to chime in.
Because so many of you could answer this question or add to it. Does anyone else want to address what research and treatments are currently being studied for CF chronic pain and joint inflammation? Maybe Dr. Irizarry as a physical therapy.
Yeah, this is hard. I agree that research is limited, and I would say from experience, it is a problem. But then when we talk about our orthopedic patients who don't necessarily have CF, when they have chronic joint pain, I know a lot of orthopedic PTs will say, and orthopedic surgeons will say, it's your bone and that area is sort of like a crayon, and when you rub it down and that cartilage is gone, if that is actually what's happening in these patients, that is really, you can't get that back. And so building the muscles is one way to help. I tried to do a brief search when I saw that question popping up, and I didn't see anything, so I apologize.
I wanted to contribute a little bit to this question as well.
Yes.
I'm not aware of kind of also of the studies, but I also want to say, especially when it comes to living with chronic pain, right? There's also such an important mental health component with, associated with that as well, right? Potentially even some psychotropic medications can help to modulate some of the pain responses, but also working with pain psychologists, right? And working even potentially with ACT, right? Or cognitive behavioral therapy with some other approaches. Sometimes in addition to medications, other medications, or doing physical therapy, working on your muscles, just really learning how to live with chronic pain and how to think about it might be a very important part of it.
And I add something myself, which is not, necessarily on the chronic pain, side. Okay. But there is, some trials mostly for palliative care interventions in cystic fibrosis. There's at least 2 consortia that I know about. One of them is mostly on the Northeast. So even though, it focuses on mental health, anxiety, and other things, part of the measures is, basically looking at, the effect that those interventions might have on chronic pain and how, this is. So this goes in what Liza said, from my perspective. Maybe we'll know in a year or 2 if those work to decrease pain.
Yeah, can I just add one thing? Also recommend, again, this gets back to communication. If your care center has specialty help, that can often be useful, both in terms of care and even research. For example, we've collaborated with anesthesiologists at our place to do a study of acupuncture and CF. So there's a lot of possibilities, and take advantage of whatever expertise is available at your care center to either get specialized input or even participate in clinical research.
Okay. All right, I think that's it. Okay, and then so this next question is, thank you so much for all being here and presenting to us from home. You're the best of the best scientists and clinicians. I have a question left over from Dr. Okori's talk, which Dr. Irizarry may also be able to contribute to. Can you comment on the need to sleep on a wedge for GERD, but also how this impacts spinal health? I wake with back pain every day due to skeletal postural pain while sleeping.
So I'll be brief in my answer because I actually think Dr. Irizarry will be like the perfect person to answer this question. But I will say, yeah, have sleeping on an incline to help with reflux. I mean, that from purely a sleep perspective, yes, that's great. In terms of the pain, I think it maybe has to do with the way the wedge is positioned. So I feel like maybe our fabulous physical therapist can comment on that.
Thank you. Yeah, this is a challenge. Some things that I would recommend that you do first is talk to your team or your nutritionist dietitian to see if there are things you can do to help reduce your GERD at night if you haven't explored all options. And then the other thing is, I think as part of your spine health routine, I think doing some yoga in the morning to kind of help get you moving in the right positions opposite of that flexed position. You are going to have a fulcrum point at probably one place very frequently throughout the evening. And if that adds up, that's definitely going to contribute to your pain. So I think also getting a foam roller can be helpful because you can do a little bit of extension and flexion at the joints above, which may also help a lot. So I would look at that yoga with Adrienne. She has some things for spine, which I think can be really helpful. And hopefully that'll help you. Even I think just getting your pain reduced a little bit can make a big difference.
All right, terrific. The next question is for Dr. Hadjiliadis. Have you seen or heard of any CF patients with breast cancer?
So the answer is I have not heard, too much about it. And I've had, I want to say, 2 patients that have had breast cancer. And it doesn't appear that breast cancer is increased in patients with cystic fibrosis, so far. Both, the patients that I saw were, with advanced age, so it was not something that's too unexpected based on their age, alone. I don't know if anybody else has, any more experience, but breast cancer doesn't seem to be something that is a lot more common in CF at this point, at least.
And nobody else wants, okay. Okay, the next question is for Dr. Corey. What research have you seen about cortisol in CF? I've seen a few papers about low cortisol in people with CF causing later wake times and abnormally high cortisol at night, causing late night wakefulness and later wake time. And it says sleep patterns very common in CF adults, as an aside.
Yeah, so in terms of, I think most of the research I've seen regarding cortisol and CF has been, well, adrenal insufficiency, I think, is a thing that can actually be a risk factor for those with CF from chronic use of steroids, inhaled or systemic, and then just also being chronically stressed, we know it can affect your cortisol levels. So I know that it can affect it in that way. So when I'm trying to see if I've seen anything I talked about like CF, adrenal insufficiency, and sleep. I got to look back and see if there's any of that kind of trifecta in the literature, but there has been discussions about adrenal insufficiency and sleep, and it is very disruptive. So I think, again, it's going to be kind of talking back with your team, figuring out, is it adrenal insufficiency caused by medications? Could you benefit from then a low dose steroid, at all the time, to kind of make up for that? And then with the pattern you talked about, but late night wakefulness and later wake time, it's a pattern we actually see common in adolescents and young adults and adults with CF. So if you're kind of thinking you're getting enough hours of sleep, but it's just shifted too late, you can actually have a way where you entrain or shift your circadian clock to go back a little bit. So some clever ways to do that would include getting low dose melatonin 5 to 6 hours before your bedtime and getting bright light right when you wake up. It's a little bit of a process of how to do it, but you can shift your circadian rhythm. So if you feel like it's just that you have enough hours and it's later, that can be shifted. If you feel like it's disrupted because of cortisol levels and adrenal insufficiency, I would definitely talk to your team about that and see what they can do to help you overall feel better. And it could be, last thing I'll say, if you do have adrenal insufficiency and your body can't mount a stress response when it needs to, when you're having an exacerbation, you actually might need additional support with steroids. So those symptoms are really important to talk about with your team.
Dr. Moss, this question says, I find your COVID-19 podcast very informative. And will you be continuing them, and for how long? Where's the best place for the CF community to get COVID-19 updates?
The way we've been doing it is as things come into the CFRI office, Siri gets in touch, and when a sort of critical mass of questions has arisen, then we do the next one. So it's sort of ad hoc at this point. But I think in terms of COVID information, it's still important to focus on your public health department in your county as well as the state that you live in. This is a problem that is very highly decentralized in the US at this point. And we could argue the politics of that, but that's the way it is. So I think that's very important. Know the website of your county health department and look at that, and the state also. And then beyond that, on a national level, the CDC, I still think, is probably the best source of information, although they've had some power to disseminate information taken away from them. So they become a little bit, in my opinion, less reliable since that power has been switched over to Health and Human Services, which is under more direct White House control. So I think you just have to keep your eyes and ears open. I know there's a certain portion of the population that's skeptical about the so-called mainstream media, but to my mind, particularly newspapers like the New York Times and the Washington Post have been very reliable and up to date in their COVID coverage. So those would be the main things I would say about going forward.
Okay, this next question, I believe it's for Dr. Conrad. Phage therapy is more personalized medicine. How will that work with insurance companies? How do we get into trials? And can we choose phage V5s, antibiotics, or shall it be supplemental?
Yeah, so a lot of these options are being discussed at this time. I think the most immediate thing that's going to come out are clinical trials with what we talked about yesterday, were these fixed cocktails, which were groups of phage that have been checked against Pseudomonas isolates that have been accumulated over the course of the country. So those are going to be probably the most immediate kind of clinical trials coming out over the next year or two. You're going to first see single dose trials, which the FDA is requiring. And very soon after that, you're going to start seeing multiple dose clinical trials coming out. And they're going to focus mostly on Pseudomonas, but there are going to be other targets coming out in the future. So what were the other parts? That was a long question. There was
yeah. Let's see. How will the work with insurance company? How will it work with insurance companies? How do we get into trials?
So the insurance companies, this is not FDA approved, so they're not going to pay for this. You have to be careful. Each IRB is checking into this to make sure that the insurance company, at least our IRB, is checking to make sure that we are not charging study-related outcomes or measures to the insurance companies for these single patient INDs. So the way we've acknowledged this, and our IRB has approved this and is providing oversight, is that we're doing these single patient INDs as adjunctive therapy to standard exacerbations. So they're built into the standard of care. We're just adding it on. Okay, so we're giving them in conjunction with standard antibiotics.
I think that you hit all the points there. Okay, let's see. They did not specify a clinician, but it says for the CF clinicians who are seeing such great improvement among CF patients due to the Vertex drugs, can you comment if you know anecdotally or through studies if CF people post-transplant have benefited from the Vertex drugs, especially Trikafta? Who would like to take this?
I can take this one. So,
okay.
So actually, just to give you an idea, there is now part of the lung transplant consortium is trying to do a retrospective analysis of CF patients post-transplant that have been on the Vertex modulators. So we are probably going to take another year, to collect all the data, put it together, and find out what there is. I'm going to tell you our experience. So we have used them relatively frequently since they came out, because we had such a good response and relatively few side effects on the non-transplant population. So maybe we have like a couple of dozen patients that we've tried them. The problem with where we expect the benefit, which is the GI tract and the sinuses, there's not an easy way of measuring those effects. So there's a lot of subjective information. So out of the patients that we've tried them, I would say that about 2/3 have remained on them because they felt either their sinuses or their GI tract was very, was working, better in many perspectives. But for a few of them, either for medication interactions, some unusual, side effects, they decided to go off of them. So this is, basically the best concurrent information that I can give you, as far as what, we are doing them, for right now. There are medication interactions. We've stayed away from using them on patients that are on nasal antifungals because the interactions are very significant. The interactions with general immunosuppressive is not that bad. You need, however, to have a lot of checking of blood work to make sure that the levels remain the same and there's no, problems with the liver or other, things. Having said that, obviously CF is a systemic disease. So I think the GI tract and the sinuses can still benefit from Trikafta. It is one thing that always is in the back of my mind. Those are, would it pass, any cost effectiveness or cost utility analysis? We're talking about a very expensive drug for something that is not easily, measurable from our perspective. We haven't had pushback from insurance yet, but I can see that in the future they might give us some pushback from that.
I can mention just we have a few patients who haven't had lung transplants, but have had liver transplants. And they've been out of transplant for quite a number of years, and we've tried Trikafta on, or some of them have started Trikafta, and they actually had quite a significant response in their lung disease, and are truly feeling incredible benefit. But again, it's a different organ transplant, but the same caveats as far as interactions and monitoring hold.
All right. So I just wanted to mention to everybody, putting your questions in, please let us know which doctor you want to refer the question to. I see a lot with I think most of them don't have them. So are there any updates or trials for gastroparesis? And that's open to anyone. Would anyone care to take that one? I guess the answer is no. No, I'm kidding. Okay. Shall I just ask somebody? Okay. Well, maybe that's a tough one that we'll have to maybe direct that question after. Oh, Dr. Shamil, did you want to say something?
Yeah, I was going to say, I'm not aware of any clinical trials going on in gastroparesis. I know there are people who are interested in studying reflux, but I don't know anything specific about gastroparesis.
Mm-hmm. Okay. All right. So let's see. There's another question here regarding Trikafta. For some, Trikafta seems to be very toxic to the liver. What component or components make it toxic? And can these ingredients be replaced to make it less toxic so more people can use it? And it didn't specify, so whoever would like to.
I can take a stab at that. I think going back to Kalydeco, we know that liver function is definitely affected by ivacaftor in a certain minority of patients. So I suspect it's the ivacaftor component. I do know that Vertex is working on another potentiator, which is extremely similar to ivacaftor. So I doubt that it would provide an alternative in that regard if somebody was having liver function problems with ivacaftor. So probably the broader answer is that, and maybe Marie can comment further on this, is that there's a fairly broad interest in getting more modulators on the market from a number of companies, as well as a fair number of academic labs that have contributed. So hopefully we'll have alternatives if in fact this is an ivacaftor specific side effect.
Okay, this is for Dr. Hadjiliadis. Regarding cancer, it seems CF patients could be viewed as aging more quickly than the general population. If you compared a 40-year-old CFer to, say, a 55-year-old in the general population, as an example, would the cancer rates be similar?
This is a good question, and I think this is in general true for the colon cancer, for example. I don't think that's true for every other cancer that we have seen, and there might be specific factors that have to do with CFTR, nutrition, pancreatic insufficiency that make it true for those things. In general, patients with CF have had a lot of chronic conditions. If you think about it, you might have pancreatic insufficiency, you have some lung disease even if you're healthier, you have diabetes. So if you look at the general population, maybe it's true that you have somebody that, maybe is beyond, their years. They look, a little bit older compared to somebody else, but I'm not sure that this is different than anybody that has a significant, common, disease. I'm also going to say something, and I want to hear, from the other experts, but cancers and colon cancer and some cancers might be, more common in CF, but there's some other things that we do not see in CF. So it is very rare and very rarely reported that, for example, we have coronary disease. And even though patients with CF have a high fat, high calorie, diet, I see some of the lowest LDLs that I've ever seen in anybody, else. So to some extent, CF does a lot of bad things, but maybe we're going to find out, that they are protected for certain other things in the future. That's my hope. Maybe that's going to tell us also how to treat, other diseases. So it's not necessarily that CF per se makes you, age, faster in its own. But if you have a lot of other medical conditions, it's the same like having, chronic conditions for some other, reason.
Okay, thank you. This is for Dr. Okori. I was wondering if there are ongoing sleep studies patients can take part in, and are at-home sleep studies as beneficial as hospital ones?
Great question. I think it's hard right now. I don't think there are many sleep studies happening, at least in our region. I don't know about other parts. I would look, because I think I see that you're from Texas. At least I think you're have a very big center, and I would ask them and just see if they happen to be doing specific CF sleep studies. I couldn't really find any active prospective studies. I think a lot of stuff I read in the literature seemed to be a lot of retrospective looking back at the data, but I think more are needed. And in regards to your question about home sleep studies versus hospital ones, so home sleep studies are generally right now pretty much only approved for adults, unfortunately, because they just have an oximeter, they have a band around your chest to measure your flow, your effort, and then something in your nose to measure your airflow. So it can be helpful if you're worried about obstructive sleep apnea, but it doesn't measure your carbon dioxide. So if you're really worried about like ventilation issues, a patient with CF should really have an in-lab full sleep study. But from the pediatric side, we're hoping we can do more studies on kids with CF and just kids in general with sleep.
Okay, thank you.
Dr.
This is for
Hanley,
Dr. Oh, I'm sorry. Go ahead.
Questions. You talked about, the liver, problem, the previous question, and this is more very anecdotal, but in our, experience at least, having, treated a few hundred, patients now with Trikafta, sometimes, first of all, is if the liver enzyme elevation is mild, treat through it. It might not, get any, worse, especially if you get a good response to Trikafta. The other part about it, we've had a few patients, especially Marie Egan talked about, post-liver transplant, that they had enzyme elevation. And what we did is we reduced, the dose of the elexacaftor, tezacaftor, ivacaftor. We went, for example, and used the 2 orange tablets only. And many of the patients still got, a significant benefit on their lung function, but didn't get, the effect, on the liver, or we build it up, very slowly. So I don't know if the other clinicians have seen something like that. But if, you seem to have a benefit, and the benefit is quick, most of the patients know if they have a benefit very quickly, try and find different ways of getting on it. Obviously, if your liver, really gets, a severe, damage, that might not be an option. But other than, while waiting for other modulators, try something else.
Yeah, I agree with you, Dennis. I've done similar. We've gotten rid of like the evening dose of the drug, and patients still had the lung benefit. And the liver studies normalized. The other thing on one young woman, the only thing that bumped was her total bilirubin. So I really didn't want to reduce her dose, so I started ursodiol, and that seemed to help. It made the numbers better. So we're following her closely. So there are things that you can do without stopping fully.
All right. This question is for Dr. O'Hare. I really enjoyed your presentation yesterday. Are there programs that parents, caregivers can go through to help with stress and anxiety?
Yes, well, so stay tuned. The next phase of our study is going to be applying ACT, acceptance and commitment therapy, for adolescents with CF and their caregivers or parents. In the meantime, though, I don't know of any CF specific parent or caregiver program. That said, ask your team. That's always the best #1 resource, is go to the teen social worker. And then you can also think about treatments that we know overall are just great for stress and anxiety. So cognitive behavioral therapy, CBT, ACT, acceptance and commitment therapy. And then there's a ton of really great apps as well. So like the Headspace app, which is like a mindfulness meditation app, which is really great. I rely on that heavily for managing my own anxiety. And there's another app that I use a lot called Calm. There's Insight Timer. I'll put all of these in the chat. So, I mean, I understand too, for parents and caregivers of people with CF, time, it's not like you're sitting on a wealth of time. I'm aware of imagining that you're spending a lot of your time caring for your CF loved one and, doing your regular life. So I think an app can be a really great way, sort of first line of attack for anxiety and depression. So I'm going to go ahead and put a few of those in the chat right now.
So this question, I think this is for Dr. Moss. I find your COVID-19 podcast very informative and, oh wait, I'm sorry. I think that was put in there twice. So I will delete, I will make a note of that one. So this question is about the side effects of Trikafta. This medication is wonderful for clearing the lungs and preventing nonstop coughing. However, my daughter can't regulate her BMs and her glucose levels anymore. Also, she's not experiencing the extra energy others are benefiting from. And she directed this to Dr. Moss, Conrad, or Schmiel. Just if they could answer, any of you could answer this question about side effects.
Yeah, I mean, I'll take a stab at it and let Doug and Rick chime in. Yeah, every patient's a little different, right? And that's one of the challenges is some people respond great with no side effects. Some people don't respond as well and have a lot of side effects. And this is where you get into individualized treatment. And you can do things like reduce the dose and seeing if that makes a difference. That's probably one of the things in this patient I would do. I would probably also talk to my endocrinology and gastroenterology colleagues and say, hey, you know, I need some help there. I think that's one of the things that we try to do is because cystic fibrosis is a systemic disease, we need to consult a lot of people and other specialties. So the first thing that, and if I were a parent, I would talk to my CF care provider. As a CF care provider, I would probably try reducing the dose. And then if these things remained a problem, I would turn to my colleagues and ask for some help with managing the bowel movements and the glucose levels. Doug or Rick, I don't know if you have anything further to add.
Well, I would agree with that. We're seeing a lot of side effects that we're trying to manage, and they mentioned a few of them. And I can make stories up why some patients have more loose stools, and others they're more constipated and have harder stools. And I agree, we do play with the doses a lot, trying to go up and down. The glucose is of interest also. For a lot of our patients, I don't know why they need less insulin than they have in the past. It suggests to me that the level of stress, physiologic stress, is down lower, and so they may become more sensitive to their insulin. We've had a lot of problems with rashes, and also I noticed on the questions something about brain fog, but we've had a lot of more than I would care to have in terms of mental health issues. And we've stopped and start and stopped and start, and these mental health issues come and go with the drug. And I'm absolutely convinced that some of these mental health issues are associated with it. And again, we end up playing with the doses. We drop the blue pill, we drop the orange pill, we stop everything, get back to their baseline, and then we ramp up slowly. And as Jim said, we are depending more and more on our psychiatric and our psychologist and our endocrine consults. So,
yeah, I would just add that the interdisciplinary reliance on specialists is really one of the most beautiful things about CF centers. So, my experience has been that the hardest thing to predict is the effect on glucose metabolism. Some patients seem to have very dramatic impact, and others not. So that can be really dangerous with diabetes once modulator therapy is initiated. So I think the key is really close relationship within the center between the specialists involved, the endocrinologist or the gastroenterologist, in terms of these side effects.
With regards to those with CF, are the standard masks out there sufficient, or should they be using filtered or N95 masks? And that's for anyone who's willing to answer it.
I think we should give this to Rick as the COVID expert.
There's no COVID experts in the world, we're all just groping our way through the darkness, right? So, I mean, it really depends on the situation that person is involved with and the exposure. I'm a sort of student of dose. I think there are settings where the potential exposure is higher, and that's where the vigilance and protection level needs to be ramped up also. So you might make a distinction about whether you can wear a simple surgical mask when you're out and about versus, let's say, if you're admitted and you're in a situation where I think hospital situations do present, despite the best efforts of institutions, a potential for higher exposures. So that's where one would be more vigilant. The N95s are really still trying to be preserved for healthcare providers because of shortage issues. But the data that's come out on three-layer self-made masks or masks you can get commercially really is quite good, and the level of protection is quite high. So I think as long as you have a good fit and you have a 3-level mask with 2 very tightly woven cotton and the propylene in between, you're probably in very good shape.
Thank you. This question is for Dr. Vidyanathan. It says, my apologies if I missed this in your session, but for CRISPR-Cas9 technology, are there any thoughts or discussions yet that when this technology comes to be, will there be any FEV1 criteria for it? For example, you need to have an FEV1 of 40% or above, or do you feel it will be beneficial to all lung functions? I realize it may be too early to know.
Yeah, so it's a good question, but I think it is a little too early. I would imagine that when you start the trials might start with the sicker cohort, but we're not at the point where we're having those discussions yet. I would say maybe the best information might come from existing trials for other gene therapies. And that might be a good place to get some indication of where we might go.
Okay, oh, I'm still not. Okay, so this is, I believe, for Dr. Conrad. Given the pandemic situation in the US, would trials on things like phages be moved to centers in Canada that are not so hard hit?
That's actually it could be even a bigger question for all clinical trials. And I'm involved with a number of CF and non-CF networks, and they're all dealing with it about the same. It's as Rick had mentioned, I think earlier, is that all these centers that are doing clinical trials, they have to first listen to what's going on in their local neighborhood, to the local, and so these networks, whether it's the TDN or non-TDN or CF, non-CF, they're opening and closing depending on what's going on. I think there's still, like at least in our area, which in Southern California, we are in kind of a hot spot, more up in LA than down in San Diego at this point. But they are allowing us to open, but they're watching the centers very, very closely. And so there's still going to be an ongoing effort to open up these trials, both including phage and non-phage. So it's going to go, but it's going to go slower probably because the centers are going to be opening and closing.
Okay. This is for Dr. Moss. Is the CF Foundation tracking non-lung COVID-19 issues in people with CF? 70% of people with COVID have lingering heart damage, studies recently showed. We've seen kidney and brain damage too. Is that being tracked by the CF Foundation?
I don't really know exactly what the plan is. I know Mike Boyle has given some nice video broadcasts trying to bring people up to date. And I know they're quite concerned. And certainly the registry is a fabulous tool to collect the data that we need. I don't know the exact state of that now. But in terms of COVID outcomes, we're learning about all these other morbidities and sequelae that are more and more concerning as time goes by. And I think the questioner, raised the cardiac issue. With MR, magnetic resonance imaging, you can find ongoing cardiac damage in 3/4 of people that have had COVID infection, whether they've been admitted to the hospital or not. And another recent MR study showed a very similar 75% neurologic damage on MR. So these are rates that are much, much higher than we were previously aware of. And I think this is why this issue is going to be with us for a very long time, even if the acute phase of infection is, we get on top of that with treatment or vaccine. And CF will have to grapple with this. So I think the key is going to be through registries like the CF Foundation, the UK Trust, and CF, the organizations in the EU in particular, all around the world where there's cases, people are going to need to be collecting this. And we have, as providers and as investigators, will have to factor this into our ongoing programs in an integrated way. So this is going to impact everything we do. And it's a new world out there, and that it's in some ways an irrevocable change, at least for several years. So we have to all get used to it and sort of integrate that into our clinical and research programs.
The next question is for Dr. Hadjiliadis. Has the CF Foundation updated standards of care to include colonoscopy for CFers at 40?
Yes. So there is basically, if the guidelines, that's what the idea behind them is, that this is, now the standard of care. And the CF registry is now collecting that information, whether a colonoscopy has happened over the last 5 years and what the findings are. So that's the idea. Now, they don't collect a huge amount of information out of this because you have to balance also how much information we have to give in the registry. There's a lot of questions and a lot of work, but they've started to collect it. And part of this is to find out what the outcomes are, but also to find out what the uptake is. So, is this something that, patients are doing, providers are doing, or they're not buying it? And so that's, things to be known in the next, 4 or 5 years. We'll know a little more of what is happening.
And I guess a follow-up question for you is, we have colonoscopies for colon cancer, but how can we be screened for small bowel cancer?
Yeah, I think this came up, in the session also. There is no good screening for small bowel cancer at this point, either with CF or non-CF. The one thing is even though the risk seems to be high, small bowel cancer is exceedingly rare in non-CF populations, but also in the CF population, if you put it together. Even though the risk is high, it's a small number. So for this one, we're going to have to wait for our colleagues in gastroenterology to tell us if there's a way, that we can screen. But there's no good way to screen effectively for small bowel cancer.
All right. This is for, no one was specified, but it says, can anyone tell us why fevers in CF patients at night are so much more common than during the day? I have fevers almost every single night. That's interesting. Let's see.
There is chronic variation, if I might take, something on this, of temperature anyway, between, daytime and nighttime. So we might see, more, higher temperature, at different times, at night. But the other reason behind it is mostly chronic infection in many cases, not in every case. So in general, when there is, a chronic, infection, there is an exacerbation, there's infections with non-tuberculous mycobacteria, more on the chronic side, that might be the reason why there are fevers. There are other causes too. So the best, way to go, about this is make sure that you're in touch with your CF center to find out what might be the cause, of fevers, and try and get to the bottom of this and treat it. I don't know if anybody else wants to add anything from my perspective.
All right. So nobody else wants to add anything to that?
No, I would just say I agree with Dennis. There are a lot of things that can cause fevers. We've had drug fevers, we've had chronic sinusitis, we've had, non-CF related fevers. It's a common problem. And in my experience, it usually presents as kind of like night sweats and kind of a more chronic symptoms. It's a real challenge, as Dennis had suggested, because it sometimes takes a while to figure out. But it typically means that there's some chronic inflammatory process going on. It could be infectious or non-infectious, and to work closely with your clinicians to try to figure it out.
Could it ever be normal to just kind of feel hot, or at night, to just as part of CF, or is it pathology?
Feel hot or have a fever, because there may be two different things.
Yeah.
I don't know. I wonder, I don't know who asked the question, but I wonder if that's what if it's an actual fever where they're measuring temperature, or if they just feel hot and maybe sweaty.
Well, I think, you know, years ago when, you know, people were more sick or less healthy and came to the hospital more, we'd monitor their fever curves. And some patients at their baseline almost seemed to be a little hypothermic. So a fever of 99.8 or a temperature of 99.8 was actually a fever for them. And again, I think that's due to, I think their brain recalibrates when they have a chronic infection. And so it makes it very difficult. And I think it is probably related to kind of a systemic inflammatory response, as Doug indicated. And it can be very frustrating for the patients and the families. And as Dennis said, we need to, you need to look for other things to make sure you're not missing an infection someplace else. If someone has a central line, for example, you want to make sure they don't have an infection of their central line. So certainly in pediatrics, we don't see it like we used to back when dinosaurs roamed the earth when I started out. But I'm sure some of the adult providers probably still see these patients who, you know, come in with a temperature of 97 point something, or their baseline is 97 and they get up to 99 and they're breaking out in sweats and everything else.
Okay, all right, thank you. This question says, being in the 10%, are there any types of supplements? So I'm assuming the 10% of they can't be treated with modulators. Are there any types of supplements you would recommend to help immune system? And it's directed to anyone willing to answer it. So.
Well, I guess I'll take that one, not to answer too many questions, but you know, we've looked at anti-inflammatory effects of a lot of different supplements. In general, what you can say about them, and or there's been a lot of studies, is they're usually too short and not enough people to see a difference between people taking the supplement and those who aren't. And so, you know, studies might be 2 weeks long and have 50 patients, and that's just not going to be large enough. They've studied fish oil, they've studied every single vitamin you can imagine. There's been other studies. We certainly have used vitamin E for its antioxidant effects, but there are no studies demonstrating that. What I would tell people, and what I talk to my patients about who want to use nutritional supplements and other therapies, is I don't have any problem with people using those therapies as long as that doesn't impact the therapies I prescribe. Like, they do that instead of the things that I recommend. But I do need them to tell me about it, because remember, many of the pharmaceuticals we have came from plants. And so these nutraceuticals and supplements can interact with the therapies I prescribe. And then I have to look that up. And so, for example, sometimes high doses of calcium will bind up some of your medications in the gut so they don't get absorbed. So we need to know about those things, and we need to investigate. So that's the deal I work with my patients, is I'm okay if you continue your CF therapies and you tell me about them. You know, but these supplements do have activities, and you have to be very careful, because I think some of us with gray hair know the story of selenium back in the 1980s, where it was thought that selenium supplements were the cure to CF. And so people started swallowing mega doses of selenium, and there were actually 2 deaths from selenium toxicity. So that's why it's really important to talk to your CF provider and tell them what supplements you want to take. And some of the things I've never heard of, so I have to investigate. So that would be my advice.
Can I just add one thing to that? I agree with everything Jim said. I've been struck over the years that in some cases, the normal vitamin, mineral type supplements that are called for in CF may not be covered under their insurance plans, and people can be in a situation of economic insecurity that prevents full compliance with what's recommended. So in general, just in terms of general health, you know, one of the reasons behind the annual lab screen is to look at things that are relevant. And, you know, in my mind, vitamin D is a good example of that, where CF patients are at risk for having low stores of vitamin D, may need supplementation, need to work with the nutritionist. Sometimes it takes a special effort to get replete. And those are the kinds of things that I think will stand people waiting for better therapy, you know, better basic therapies in good stead if they do that.
I didn't look at the time, but I did now, and I don't want to start the next one late. So I'm going to have to end it there. And I hope there were a lot of questions, and I really thank everyone for asking them. And I hope maybe you can contact CFRI and you can get in touch with who you wanted to discuss the question with. So thank you. So many thanks to our esteemed panel of speakers for sharing your expertise and insights, and to all of you for your participation. Though they did say that CFRI will collect the rest of the questions and do our best to have them answered for you after the conference. It's an honor to be your moderator, and thank you very much.